Hello and welcome back to Hill and Ponton's YouTube channel. I'm attorney Allison Reddick, and with me today is my
Attorney
favorite
Rachel Cheek
to work with, attorney Rachel Cheek. I was trying to give you a better intro and you just cut me off there. Okay. So we are back this week to answer questions, two new faces that you haven't seen in a while. So we're here, we're ready to answer all the questions that we have. So let's start. Rachel, you want to start us off?
Sure. All right. This is from Memeing8030. It says, "Hi, I'm service connected for tinnitus, and according to my decision letter, I had hearing loss above 4K hertz. Is that number enough to put in for a hearing loss claim? I'm not sure how to read the VA hearing loss chart. Thanks."
So it's less about the level of hearing loss and more about the speech recognition, because that's really where the hearing loss chart comes into play. Even if you have hearing loss at these certain decibels, if your speech recognition is 100%, you're still not going to get service connected for it. If I would put in a claim, because what's it going to do? It's not going to hurt anything, because that could show that you have really bad speech recognition. And if it's below like 90%, you can probably get like a 0% rating. But at the end of the day, it's not just about the decibel level. It's about your speech recognition. And you're not going to know that unless you do the Maryland test that is the standard testing for hearing loss. So if you got service connected for tinnitus, that means there's something going on. Tinnitus and hearing loss really go hand in hand. I would put in a claim. And from there, you can see based on your audiogram whether your speech recognition is low enough to entitle you to a compensable rating, because that's where it's going to be. I'll have people who say, well, I have hearing loss, but if you have 95% speech recognition, it's not going to do anything. And these testings aren't that great because they do them silent. So obviously you're going to be able to hear things, whereas a lot of people have hearing loss when there's background noise. So that's why, even though you have hearing loss, those speech recognition percentages are going to be high because there's no background noise. So I would put in a claim. What do you think, Rachel?
I agree. I think the way that VA rates hearing loss, even though you might have hearing loss for like day-to-day purposes, you don't always have it for VA purposes.
Mm-hmm.
But the fact that they've already linked tinnitus to your service, I think definitely worth it to put in a claim.
Okay, what do we have next? We have McGoddle. Hi, 100% P&T, permanent and total. 60% is of arthritis of the hands. If I were to get SMCK of the hands, would that mean they should give SMCM? Thanks for what you all do. Okay, so SMCK is to get SMCM, you have to have loss of use of both hands. So even though you have a 60% rating for the arthritis of the hands, that means it's pretty extensive. But to get that special monthly compensation, you have to have no use, which basically means your fine motor skills are deteriorated. You can't like pick things up. You're unable to button buttons and zippers. Those fine motor skills are lost. That's the difference between getting that special monthly compensation and getting that 60% rating. That 60% rating is pretty high. I know for the back and for like peripheral neuropathy, that's probably more similar. If you don't have atrophy of the muscles, then you can't get that higher rating. But for this, it's more or less going to be a loss of use test that's needed. So if you want to try to get the SMCK, you need to not only put in for an increased rating for arthritis of the hands, but specifically request loss of use of both hands. And so if you get loss of use of both hands, then you can get the SMCM. But if you only get loss of use of one hand, it's just going to be SMCK.
Very well put. And I apologize. Allison's answering these very well. I was having some audio issues, but I can hear perfectly now.
Oh, you can ask the next one.
There we go. All right. This is from Rumi86. Hello there. How can I connect my GERD secondary to my service-connected disabilities, MDD, major depressive disorder, peripheral neuropathy, migraine headaches, and MTSS? Thanks for all you do. All right. And this is a good question because so many things are secondary conditions that you might not be related to your primary, but somehow probably is. I'll be honest, I am a lawyer and not a doctor, so I did have to look up the abbreviation of MTSS, and that is medial tibial stress syndrome, overuse injuries of the lower extremities. So
I can tell you what I think.
All right.
Go ahead off the bat. I'm thinking medications because that's where you're going to get that secondary service connection. What medications you take for the migraine headaches, the gabapentin, maybe for the peripheral neuropathy. I'm not sure right off my head, but what I would do is I would Google all of your medications and see what are side effects to these medications. That's the first thing I'm looking for with these specific conditions, because when you look at them, it doesn't really look like you can get it service connected. I hear people all the time tell me they have GERD secondary to major depressive disorder. I'm not a doctor. I don't know how that's connected, but the only way I could see it getting connected for any of these would be the medications. Sorry, Rachel, go ahead.
No, I think that's a great answer. I was saying, perhaps if nausea could be related maybe to migraines, you might have those with nausea. You might have something to be able to pin together that symptom with GERD. But I agree with Allison, looking at your medication list. I mean, how many medications is nausea a side effect of? I think, and not that that's all that GERD is, but that's kind of a big factor of it. So I definitely agree. Check out your medication list and see what those listed side effects are.
But I think you bringing up the migraines, I didn't even think of that. Nausea and vomiting. If you're having that vomiting and you're having that reflux, that's a really good point too. So that's another way. There's so many different ways to think about that, and medications in one, and nausea from and vomiting from severe migraines. That's a good point too.
Mm-hmm.
Okay, Twisted L. I'm filing all my claims on my own, but it seems a VSO would have access to certain things I need from my file. Can I go to a VSO and get just what I need and nothing else? So if you go to a VSO, the first thing they're going to say is, I can't tell you or help you or do anything unless I get a 22 form from you, which is basically a veteran service organization officer representation, which kind of makes sense because then they can get access to your file and see things. But at the same time, I mean, I'll have people who call me and I'll give them advice when I don't have access to their file, but probably not. They're most likely going to want to get a 22 on you so they can get access to your file, and then they'll help you file your claims for you. But honestly, they know how to file the claims, and they can probably get it processed in there quickly, and they can see if it's in there. You can just have them file your claims for you and then do nothing else. It's not like they're going to take a fee or anything like that. You have anything to add, Rachel?
No, I think that's a good idea. One thing I would ask for, I think you could ask for the VA directly. I know sometimes the VSOs say they're not able to give copies of your claims file to you, but you can request that from the VA itself. So if you were concerned about some service records that you needed to review, they are your records, so you can request them. Obviously, getting a copy takes a lot longer than a VSO signing a representation document and being able to look at your whole file within the next week. But I agree with Allison. They're not going to just download the file for you. If you're concerned about working with someone, you could certainly try to request it yourself first. But again, it doesn't hurt to get your claims filed by someone who knows the process and how to file it. If you're not happy with the decisions that you get, then at that point, you've got your claims file, you kind of know what's going on. You can make a decision from there, what you want to do.
And you would do a Freedom of Information Act request to get access to your claims file. And also you can always put in an intent to file to protect your effective date, because the longer you delay putting in your claims, that's going to be the effective date. And when you put in an intent to file, you have a year from that filing to file any claims, but they all have to be on the same form. If you put in an intent to file in January and then February you file for depression, and then in June you file for neuropathy and a back condition and tinnitus, that intent to file is only for that February claim. So when I tell people they're going to do an intent to file, make sure you have all of your information and wait until you have everything ready and all of your claims you're going to file at once, because that intent to file is for that next claim that's filed. Well, you could file the depression in February, and then you could put in a new intent to file, and then that would protect the next claim that you put in. But it's important to know that it's only for one claim form that intent to file covers.
That's a good note. More from Twisted L here. This came up perfectly as you're talking about a FOIA request. I've heard that an open FOIA request could possibly pause any claims filed after the FOIA. Is this the order it was received thing I keep hearing about? And if so, can I withdraw the FOIA?
So I do see this happen a lot at the board. I will see a case ready for a decision and it'll be stuck in privacy. And it's because of that FOIA request that it's been paused. So yeah, absolutely. Sometimes the FOIA request can pause open claims at the board. I don't know about at the regional office. I've never run into that there, but at the board, I have seen the case be paused and it's stuck in the privacy office waiting for that FOIA request. So at that point, what we do is we withdraw the FOIA request, and then they move forward with adjudicating the appeal. RV, got a private DBQ and IMO for sleep apnea secondary to sinusitis, asthma, and allergic rhinitis, and still got denied for having no service connection. That's the reason I paid for it. Any other advice? Rachel?
So I went to look at that decision, and I guess I would need to know a little more, because you say you have no service connection, but this opinion posited that sleep apnea was secondary to sinusitis, asthma, and allergic rhinitis. So I think what I'm reading is that you're not service connected for those conditions either.
No, I think he's service connected for I'm reading it like he has service connection for those conditions and not for the sleep apnea.
Okay.
Even though he filed a private DBQ and IMO.
I gotcha. Okay. So one thing you could do is just review the decision and see what it says. I know that sounds pretty simple, but sometimes all of the evidence will be in, it's supported by records. And then I'll get to looking at the rating decision and it'll say, like, your claim was denied because you were no-show to a CMP, and we can't make a decision that way. I see that happen a lot, and it's frequently in cases where veterans either didn't mean to miss the CMP, they didn't know it was scheduled that day, they were out of town, they had a medical situation, all kinds of things can come up, but the VA doesn't care about it until you inform them. So that's just a general tip is make sure you always see the reason why something was denied. Now, probably what they said was, we received your private opinion. However, the CMP from our doctor was of more probative value. They love to say that. So really what you have to do is kind of see what they've used as their reason for denying and then kind of go from there. So are they saying that your examiner wasn't qualified, or that your private opinion doctor wasn't qualified? Are they saying that they found the evidence more probative from the CMP exam? Well, then you can kind of look, and maybe you can go back to that same doctor and say, look, I got a denial from this. This is the CMP that they denied me on. Can you address this rationale as well? Sometimes it's just you haven't had a chance to address the issues that the CMP examiner comes up with to deny, and VA just makes the decision. What do you think, Allison?
I agree with reading the decision, because a lot of times it is that you didn't go to the CMP exam, because even if you get an opinion, VA is always going to want their own opinion as well. And like Rachel said, they're most likely going to say, well, their opinion's more probative without giving any reasoning for it. I also notice in a lot of private DBQs, they'll be filled out, but there's no at least as likely as not language. And just because a doctor fills out a DBQ, they're not necessarily giving the information needed to service connected. So they have to say that the sleep apnea is at least as likely as not secondary to the service connected sinusitis, asthma, allergic rhinitis.
Magic words.
Yes, those are the magic words. Additionally, a lot of times they'll want medical research. Even though they won't do that with theirs, if the doctor says, you know, I've reviewed the medical literature and pulls out a couple articles and says that this shows that this condition is secondary to, that helps as well. But really, all you really need for secondary service connection is the doctor saying that it's secondary to those conditions. So if it's saying that sleep apnea is secondary to those conditions, the doctor is saying that at least as likely as not, then it should be getting service connected. But we don't have all the facts. Like Rachel said, if they do deny it, try to go back to that person who originally wrote the opinion and see if they'll get an addendum to refute whatever the C&P examiner said.
I thought of another thing with this is sometimes I would make sure also when reviewing that rating decision, they've got a list of evidence that they look at. Every now and again, they don't even look at a piece of evidence that we submitted. Or if they looked at it, they didn't put it in the rating decision as evidence reviewed. So that could also be something I would check to make sure it's on there. You might just be able to file like a higher level review if they say they've reviewed it, but then clearly didn't.
Yeah. Or you can file a higher level review because you have to remember when you're filing an initial claim, it's the lowest rung of employees that probably don't have very much experience. Whereas the higher level review is someone who has more experience at the VA. Now, higher level reviews are hit or miss, but when they hit, they hit. I mean, like you can get some really good decision review officers when it's something obvious like that, that will overturn the decision and give you service connection. Okay. Yolanda Frug Adams. Hi, Matt. Hey, Matt says hi. Did an HLR for 2 conditions. VA said it was duty to assist, DTA. This was June 23. Went to new C&P and found was service connected. Have heard nothing since. Is it time to squeak the wheel? Thanks for all you do. So are you saying that you went to the C&P and the examiner told you it was connected? Because a lot of times they'll tell you one thing and then something else will happen and it's not service connected. A lot of times I'll see a positive Nexus opinion and then VA will go out of their way to get another opinion to negate that original opinion. I'm not saying that happened in your case. I'm hoping that the new C&P exam was positive. I've seen C&P exams that are positive and they'll sit for a year and I will bug them until they make a decision on it. But right now, realistically, where your claim is, it's probably in the national work queue waiting to be pulled by a regional office to make a final decision on it. And that can sit for a long time. And it's really hard to push them on it. I have one veteran who I got a duty to assist of March last year. And all that was needed was a new C&P exam. And they still have not scheduled that C&P exam. After probably 100 emails, I finally have gotten someone to schedule that C&P exam. But now it could be in the same situation where C&P exam is done and they're waiting for a rating decision. Also, if the C&P exam hasn't been uploaded in the file, that can delay it too. So they have these suspense dates where there's 30-day periods where they're waiting for something. And if they don't have it, they'll push it out. So they could be waiting for the results of that exam, or it could be past due and it's just sitting there in the national work queue waiting for a decision. If you have anyone that you can call, absolutely squeak the wheel, reach out, call VA, ask for status. a lot of times that's not going to do anything, but at the same time, not doing it's not going to do anything. You never know. You could get in contact with someone who's nice and will push it to someone who can do something, but it's probably just sitting. What do you think, Rachel?
I agree. Could be sitting for any number of reasons, and a lot that work queue can be the bane of our existence at the regional office, because it literally is just that. It's a queue of all the claims where the evidence might be in. They're not really waiting for anything, but they're working them in order. Sometimes things fall under the between the cracks. What I would suggest, all the things Allison said are a good idea. Call, put in a status request. One thing I have been seeing, actually, not all the time, but things will start moving. Calls are great, emails are great, but you need to get something in the file if you're if you're concerned about it. And I would be after 9 months and the CMP exam being done. VA has a form 4138, and you can get that on their website. It's the statement in support of claim 4138. And all you do on there is just say, hey, this is my claim. Here's the situation. Tell them the dates of your higher level review. Tell them the dates of the duty to assist error when you went to the CMP. And I just say, can I please be updated on the status of this claim? Now, sometimes that can just go into the ether at VA and they don't do anything about it. But I found that it actually gets things moving. A lot of times it's filing things when we need something to be fixed, or there's an error or a weird delay. Putting things in writing and on the official VA forms, I've had a lot more luck with that than doing it on just a letter or just doing like a call. So that's also something you could try. Okay, it's that time asks, can they take away ED via a CMP after 3 years of service connection? And if so, why? Assuming ED is erectile dysfunction. Yep. So yes, they can. How to appeal if they do? Okay, perfect. So yes, they can deny it. They can take it away. They shouldn't. VA is not supposed to like sever or reduce claims or service connection unless there's a clear and unmistakable error, and unless you have been shown to have sustained improvement over time. VA calls it under the normal conditions of life. What do they call the ordinary conditions of life? Mm-hmm. Right. So what I could just think off the top of my head, what might have happened is you were service connected for ED secondary to a condition that you have that's also service connected. But in whatever reason, they were taking a look at this file and they stated, actually, it's due to this other condition that's not service connected. That's a very easy way for them to be able to take a rating away or reduce your rating. What you could do to appeal, first, it may very well be that you have a condition that's not service connected that can have ED as a side effect. But if you were already service connected for it, that's a pretty good indication that one of your service connecting conditions does cause ED. They might be trying to say that it's this other condition that's not related to service, but they can't do that unless they show that your service connecting condition that ED was secondary to doesn't cause it, if that makes sense. Can you put this into clearer words, Allison? Do you know what I'm trying to say?
Basically, it's a case. I think it's Mitlider, that if you have a non-service connected condition and a service connected condition that caused something, you're supposed to put the benefit of the doubt to the veteran and say that it's the service connected condition that causes the condition. But yeah, your ratings are not protected. Even like after 10 years, like after 5 years, you get a little additional protections. After 10 years, you get a little additional protections. Your ratings are not protected to be taken away until after 20 years. But I'm thinking it's probably the situation that Rachel's talking about. A lot of times they'll reduce or sever something after one CMP exam. And like Rachel said, the ordinary circumstances of life, like you can't do that after one CMP exam. We would definitely need to see the actual facts of the case. I think she gave the best possible scenario of a guess of what happened, but the answer is yes, it can get severed, and yes, you should appeal it.
Yeah, he noted it was secondary to diabetes and doesn't show any improvement.
Oh, that definitely should be service connected.
Yeah, that should absolutely. I wonder if you can get that it documented that you have no improvement and that it's due to service connected diabetes. I would think that would be enough to appeal.
Tony Halavac. 8 years ago, decision letter, 20% for radiculopathy. I have a new diagnosis for foot drop on the same leg. Is that a new claim or supplemental? You could go, okay, first of all, 8 years ago, you filed for radiculopathy. Did you ever file an increase for it? Because if you never filed an increase for it, then it's going to be a new claim regardless. That's one way you could do it if you never filed an increase. If you did file for an increase and it would have to be a supplemental, the diagnosis of the foot drop on the same leg would be new and relevant evidence. I would reopen it as a supplemental claim, or if you hadn't ever requested an increase, I would request for an increase of the radiculopathy with consideration of the foot drop. What do you think, Rachel?
I agree. It's kind of hard to tell until, if you've filed a new claim or if you've ever filed a claim for increase. Annoyingly, VA will put that in the same category as if you're filing a claim for a new condition you've never claimed before. Mm-hmm. But yeah, I would probably start with the supplemental claim and showing the diagnosis for your foot drop. They may get back to you and say, well, actually, you've never filed for this. You need to do a 526, in which case that's fine. You know what you could do is file an ITF right now, then file the supplemental claim. And if they get back to you and say, actually, you need to file a new claim, you've still preserved that date of your filing. And vice versa. If you were to file a new claim and they later say you need to do a supplemental, if you have that ITF filed as soon as possible, that will preserve your effective date, regardless of which form VA tells you to use. So I would probably do it in that order: ITF, supplemental, see what the VA says. Anthony Rivers asks, can you request your file get pulled for quality control errors if the RVSR and higher level review still refuse to recognize the 38 CFR and or the US code? God, that would be nice. You can request it, sure, but the regional office and even at the higher level review, they don't recognize that all the time anyway. One of our biggest problems at the regional office has to do with their internal guidelines. So they do have to go by the Code of Federal Regulations and the US code, but they also have an internal manual that helps them figure out how to adjudicate different issues. The problem with this manual is it's not always consistent with what is required in the actual regulations. So, for example, for aid and attendance, there is no requirement that you have to have a certain rate. Allison's smiling because this is a big problem always. There is no requirement that you have to have a certain rating for aid and attendance. Yet, in the regulations, in the law, at the board, at the court, no rules on that. At the regional office level, their manual says generally 100% single rating is required for aid and attendance. Generally in the regional office, but not by law or by any judge. So the fact that they're not always going by the code, they might be going by according to their rules in the manual. What do you think, Allison? I think it's probably time to file an appeal to the board if you're concerned that the law is not being followed.
Yeah, I have a case right now where it's a PACT Act. He was an Air Force pilot and he flew in the airspace over Saudi Arabia in 1990 and 1991. And he also flu years before that, and he has prostate cancer, and that's reproductive cancer. After, I think it's August of 1990, if you served in those areas, you should get presumptive service connected based off the PACT Act. In his favorable findings, it says that he served in the airspace after 1990 and he has service connection. And he has a diagnosis of prostate cancer, but they're not service connecting it. And I am so confused why. Sometimes they just don't know what they're doing and they kind of do what they want and get away with it. And sometimes you're just going in circles at the regional office that you do have to go to the board, even though it takes a really long time. That's a lot of issue of the backlog at the board, is that the regional offices are making these decisions that are wrong, but they're not following the law, because the manual, the M21 that they use, that you can look up on the internet, doesn't say what the regulations and the code says. And going off of that, you don't have to have a certain rating for aid and attendance. You also don't have to have 100% rating for one condition. You can have individual unemployability for multiple conditions and get aid and attendance. And I'm writing an argument letter for that right now. And it's driving me crazy that I have to go to the board for this. But it's the VA's world. We're just living in it. And yeah.
So yeah, you can request, but you're probably not going to get very far. If it's something where they're just refusing to abide by the regulations, take it to the board. It'll be a wait, but they do get it right more often.
Remy 86.
We answered this one.
Oh, we already answered this one.
Yeah.
Yes. Look at your medications and migraines. JD Min 4. If stimulation of your lower lumbar creates the urge to urinate, is that considered incontinence for rating purposes? Stimulation of your lower lumbar. Okay, so I'm assuming you're service connected for your lower lumbar. Are you service connected for L5S1? Because that's going to be the area where that stimulation occurs. I think it's possible. Especially with the nerves, if there's nerve damage down there, absolutely. But it depends the extent of your disability, and it depends on if you can get a doctor who will say that the incontinence is secondary to the lumbar spine condition. But yeah, absolutely, I think that's possible.
Yeah, and just to note, when that's I wouldn't say common, but you see it fairly frequently, incontinence of either urinary or bowels due to lumbar spine. Do keep in mind that depending on what your symptoms are, you might be rated differently. So they will consider incontinence as, they look at the rating for that based on if you have to wear absorbent materials, and they look at the number of times that has to be changed per day. Pads, diapers, pull-ups, whatever. If you're having to change those twice or more a day, that's something you're going to be rated under incontinence. Whereas if it's where you can get to the bathroom in time, but you're having to go a lot and frequently, then you'd be rated under urinary frequency. And that is based on how many times a day you use the restroom, specifically the intervals of how many hours go by you needing to use the restroom, and how many times you wake up at night. And that would be rating for urinary frequency. So just kind of depends what you have as to which symptoms you'd want to point out. Okay, Josh B says, I filed in 2013 for bilateral lower back pain, and the examiner stated it wasn't service connected. I was reviewing my military records to get my documentation together to file more claims, and found that I had an x-ray from service with L5 sacralization and back pain complaints from my deployment to Iraq. How should I approach and address this? Can you go back to that first slide, please,
Yeah,
Nick?
that's the first part.
Okay. So, it was stated that it wasn't service connected, but you had back problems in service. So what I'm thinking could have happened if the examiner, if those records were available at the time, at 2013, even though, of course, those records were in existence before 2013, sometimes VA finds them later and puts them in your file. So it kind of depends. I'm just going to assume that your records were part of the file when the examiner reviewed this in 2013. Check out that decision, because it may be that the examiner said, yeah, you had these back problems during service, but they were acute only. They love to say problems clearly documented in service are only acute, meaning short-term, resolved quickly. Where you get into combating that, you'd need to file a supplemental claim. Since this was in 2013, your initial decision, you'd file a supplemental claim because you're filing for service connection again. And what you'd want to do is, now that you know you had these documentation during service, you'd want to reference that in your claim. If you could put copies, all the better. And you'd also want to note that not only did you have these back problems during service, but since that time, you've continued to have back problems. And you need to basically go chronologically. You can just kind of go, after when I was in service, here were my symptoms. Shortly after service, when I got out, these are my symptoms. Maybe your friends and family noted that you walked differently, seemed irritable, were in pain, couldn't do as much stuff as you used to be able to do. It really helps if you have family members or friends who would be able to attest to how you were before and after, and witness that you had a change during service. Because in this case, you've got your in-service incident and you've got your current disability. You have to show the continuity of symptoms between those, that in-service incident and your current status. Alternatively, you could also get a medical opinion, which links your service together. But I think in this case, you already have documentation that it happened. So I would start with lay testimony, just your own words. What happened? Have you been treated? What have your symptoms been, etc.? Allison, what do you think?
I agree. I would say this is more recent, so you definitely may be able to still be in contact with people that you served with that can corroborate that, you know, you had issues with your back in service. Family members giving testimony that before you went to service, you were healthy, you were an athlete, you had no issues, and then you came out and you're suffering from back pain all the time. Showing that continuity of care, because a lot of times people don't go to the doctor for back pain or migraines or things like that, but you can get lay testimony to support that you did continue to have issues with these conditions and it wasn't an acute episode. So definitely filling in the gaps with lay testimony. Medical records are even better if you have them. Definitely lay testimony. Don't depend on VA to go get your private medical records. You need to get them and send them in yourself. And then that may reopen for you to be able to get a new C&P examination and have someone re-review it. But then also, if you get a medical opinion and they say that they reviewed your claims file and your service records and they say that it's due to service, that's going to be helpful as well. But I agree to definitely start with the lay testimony.
Mm-hmm. I thought of another thing, which often comes up with, especially with back problems when you're young. They might have said that, yeah, you had this during service, but it was acute only because it wasn't mentioned on your exit exam. So I would check and see if you can see that in your decision if they mention anything about your separation exam, because not that I've undergone one, but from what I've heard, they're pretty quick, kind of cattle call. They don't really spend a lot of time examining you. And at the point where you're trying to get out, you maybe not are going to mention like something that to you seems minor at the time, like a backache. So if that was addressed in your previous decision, I would get out in front of that in your statements when you're describing how your symptoms continued. If you didn't mention it in your separation exam, why? Maybe you just didn't want to complain, wanted to get out of there. Maybe it wasn't a problem constantly, but it became a recurring problem later.
Okay, Dr. T.E. Russell. Hi, how do I take off the TDIU and just keep my 100% scheduler? If you have a 100% scheduler, they're going to take off the TDIU automatically. You can't have both. And if you have TDIU and then your ratings increase to the point where you have 100% scheduler, you have 100% scheduler. There's no more TDIU. So there's nothing that you need to do to take off the TDIU. If at any point your ratings increase to a scheduler 100% rating, the TDIU goes. You don't have to worry about not working and limitations of earnings and things like that.
I would too, on the safe side though, if you have had TDIU and then got 100% and you want to start working again, that's why you want to get rid of the TDIU. I would just call VA or submit a statement and let them know like, hey, I'm working, or like just kind of give them a heads up. Even though Allison's right, they're not going to give you two at the same time. I have sometimes seen that come up when even it'll still say that you have IU, even though you have your 100% rating, even though technically you're not receiving it. So if you're really concerned about wanting to go back to work again, it would probably ease your mind if you just call the VA, let them know, speak to someone, hey, put in my record. Roger Smith, I received a letter confirming 100% for prostate cancer and informing me to file for ED because of heart disease. 100% not permanent. What is ED worth as compensation? Okay, good question. So the reason your 100% wasn't permanent, that would be because active cancers are rated at 100% while they're active, while you're receiving treatment. If you go into remission or once the cancer is no longer active, they're going to rate you off of residuals, which for prostate cancer could be the incontinence or urinary problems we talked about before. For ED, that is rated at a 0%. So there's no compensation technically from ED except special monthly compensation. So special monthly compensation, you probably hear us talk about it all the time. It is basically a way for you to get above and beyond 100% rating disability. Disability combined ratings only go up so far, but as disabilities increase or different things come up, you may be eligible for special monthly compensation. One big area of that, special monthly compensation for loss of use. That is what ED is considered as. ED, female sexual arousal disorder, hysterectomy, any other kinds of conditions that involve the reproductive system, if they are related to your service and you can no longer use that creative organ, is what they call it, you're entitled to special monthly compensation K for loss of use. And I want to say right now that it runs at about $130 a month, $140 a month?
I would say it's around $100. But to clarify, you don't have to have 100% rating to get SMCK. It's a loss of use. So you get ED all the time. It's just not going to add to your combined rating. It's going to be 0%, but you can get that SMCK and get that extra $100 a month for the ED. Last 5 miles. Hello, attorneys, Miss Allison and Miss Rachel. I want to thank you all for all you do for the veterans. Keep up the good work. You do make a difference in our lives. Thank you, H&P. Take care. That we truly appreciate that. At the end of the day, all we want to do is help veterans, and we can't help everyone, and we can't take every case. And this is an additional way for us to help the people, the cases that we can't take, or the people who want to try to do it on their own. So we truly appreciate the positive feedback. And, if you ever have any additional questions or videos that you want to see, like I saw someone wrote that they don't understand how to read the hearing guide. We can make a video on that and help explain. So we're here to help you in any way we can.
I think we might be the only few lawyers who enjoy our jobs. All right. Spanky Spangler asks, are positive VA doctor notes enough to establish a nexus? Doctor says IBS, rhinitis, and heart issues are related to toxic exposure. Good question. Kind of.
It depends.
It depends on the notes. Well, for one thing, I guess I'd want to know what your toxic exposure is for. Because if you have like presumptive exposure, maybe in Southwest Asia, Some of these conditions are going to be presumptively service-connected. So I think IBS and rhinitis kind of stands out there. You might not need the Nexus. However, it certainly doesn't hurt. And if it's related to toxic exposure, like within maybe you didn't have service in these presumptive areas, but you had exposure to chemicals and solvents and stuff during service due to your job duties, that could also help if they could specify the type of toxic exposure.
Yeah, like if you served at Fort McClellan and your doctor's saying you had toxic exposure, VA doesn't always recognize it, and that's not necessarily going to give you the Nexus. You're going to need a more in-depth IMO discussing the scientific research and literature, discussing the chemicals at Fort McClellan and where you served, et cetera. But like Rachel said, if you have service in Southwest Asia in the time periods where it's presumptive, you have that IBS diagnosis, that should be presumptively service connected. The other ones are going to be a little more difficult because they're not presumptive, and you're probably going to need more, but it's a good start. PVT Robert, is sleep apnea secondary to tinnitus? I saw this and it makes me laugh because it can be. I've seen it secondary to tinnitus. Now, if you have mental health or you have neck issues or you have any other condition, I'm going to go for the other conditions because it's easier. But I've been seeing sleep apnea secondary to tinnitus more, and you just really need a Nexus opinion. The tinnitus affects your ability to sleep. It affects your REM cycles, and that can lead to disordered breathing. It's a lot more difficult. I don't see it all the time. I see it denied, but lately I've been seeing it possible. What about you, Rachel? Have you seen it?
I can't recall off the top of my head if I've seen that particular connection, but I agree with you. If you have other service connected issues, it probably will be a little bit easier to get connected. Or you could do those, you could add them in. Like maybe if you have even not your neck, but like a back problem with like chronic pain, anything that interrupts your ability to sleep soundly, I would try to bring in like as much as possible. If tinnitus is your only service connected condition, then go for it. I mean, the worst they can do is say no, and then you know what you have to prove. You'll probably need a Nexus.
Yeah, if you can get a Nexus, go for it. Even without a Nexus, sometimes God, what did I just see? I just saw a CMP exam that granted, what was it? Oh, depression secondary to hearing loss, which makes sense. But a lot of times we have to get Nexus opinions for it. You never know. I would say majority of these examiners are not great, but there's a good percentage that I've been seeing some really good opinions lately that are surprising. So it never hurts to try. Most likely you're going to need a Nexus opinion, but go for it. I've seen it.
All right. Marjan Magsamble asks, so I'm from California, so my Nexus letter should be in the same state? Not necessarily. Depends what your Nexus letter is for. If it's for something that you need to be examined, trying to think, like if it needs to be something that you're seeing in person, a Nexus letter is a little easier than an examination because you don't technically need to be in the same state. Provided that the doctor has access to your claims file and your records and is able to review them. It always helps if they're able to have an examination, or if it is like a mental health condition, or honestly, any condition probably would help to at least have a phone conversation or discussion with the doctor. I think any way you can show that the doctor like really is applying these facts to your case is helpful. They don't necessarily have to be in the same state. It's a little, I think it does give a little more weight when the doctor is local, when it's someone who sees you in person. But we have a lot of doctors that we work with who are not in the same state as veterans, who they're able to give good detailed reports for because they have access to their files and are able to communicate with the veterans. What do you think, Allison?
No, I don't think it has to be in the same state. I think they're always going to want an opinion from someone who sees you more than once. So if it's something where it's mental health and you can talk to them a couple of times, great. If you fly to someone and have them do range of motion, great. Range of motion is something that doesn't matter who does it. It's going to be not always the same, but it's concrete in that anyone can do it. The only negative I would think would be that sometimes I'll see that they'll say, oh, well, you got this opinion and they only saw you one time. Well, when they give you C&P exams, they only see you one time too. So I don't think it needs to be in the same state. Like Rachel said, if they're local, it looks better, but there's no requirement saying that it has to be in the same state.
Yeah, for a long time, VA didn't like psychiatric examinations to be done over video conference.
Yeah.
But let me tell you, COVID changed all of that. Now they do C&Ps by video conference. So yeah, I agree. It doesn't have to be the same state.
Wayne K. Have 40% for hearing loss and tinnitus, had C&P November 23 and got 10% increase. Just had private audio exam and speech recognition is 32 right ear and 28 left ear. I'm deaf. Can I file for total deafness? Now 92% total. If that's going to increase your rating, absolutely. Just because the C&P exam said one thing, that's just like the range of motion. It's concrete. Like you have a private audio exam that shows that speech recognition, that's low. I mean, I'd have to look at the chart to see exactly what it is, but if it's going to give you an additional rating, I mean, you probably need 20% more to get to 100. That's a guess. I don't know. But yeah, file a supplemental claim with that private audio exam and hopefully that'll get you up to the scheduler 100%.
Agreed. Now, one thing to keep in mind is that VA's hearing loss ratings require the Maryland speech recognition test, which is how they get that speech recognition. And your private audiologist might have used that. I know. What's that?
Most likely.
Yeah. I know that it's not something that's always used anymore. It's a little older. But I would just caution you that if it's not the Maryland speech recognition test, and they might throw it back and say, well, this isn't, the proper testing. But I think the fact that, as you say, this documents that your speech recognition is extremely low, that sure sounds to me like that's going to be, even if they were testing it with a bit different speech recognition test, I would expect that the official VA one would be pretty similar. So definitely go ahead and file it. And another thing with deafness is kind of goes along with like loss of use, in that it can potentially entitle you to special monthly compensation. So if that's something that you're struggling with, definitely file for that and pursue it. Priscilla Jones says, hello, I recently had lung resection surgery and the chest tube suture area has left me with numbing sensation across the midsection abdomen. Can I file for aid and attendance? Right? Aid and attendance for emphysema together. I'm 90% service connected and IU. Oh, so you're asking, can you file for aid and attendance and emphysema at the same time? Yes. Although kind of sounds to me, you might want to file for some kind of nerve condition if you're having numbness after this surgery. But yeah, you can file for anything together. Aid and attendance does have, when you file for that, they do want you to fill out the form, or your doctor to fill out the form 2680. And that's the DBQ for aid and attendance. And if you're saying that emphysema is the thing that's causing your need for aid and attendance, the doctor needs to indicate that. and note that on the record. But as far as filing the claim, there's no reason that you couldn't file them together. Do you have any thoughts on this, Allison?
If you have issues with your activities of daily living, bathing, going to the bathroom, eating, dressing, and it's due to your service-connected conditions, then file for the aid and attendance. If you're not service-connected for that emphysema, don't put it on the aid and attendance form, because they're immediately going to say, well, you're not service-connected for this, and this is why you need the aid and attendance. You have 90%. I'm assuming there are other major issues there that could be affecting your ability for aid and attendance. So either you want to get the emphysema service connected first and then file for the aid and attendance, or you can file for them both at the same time. But I'm telling you, if that emphysema gets denied, they're going to deny the aid and attendance too.
Yeah, but file.
Spanky Spangler had PACT Act ITF in place before deadline. VA used the ITF to process TDIU. Any way to get OTF back? What's OTF?
I'm not sure.
Had PACT Act ITF in place before deadline. VA. So I'm guessing that
ITF, I assume. Sorry.
ITF back. I'm guessing that maybe you had an ITF in place for a PACT Act issue, but then you filed for IU prior to. Like I said, IU counts for the ITF too. So if you place the ITF and then you filed for IU and then you filed for those PACT Act issues and it was after the deadline, it's only going to be effective for the IU. Are you reading that any differently?
No, I'm with you on that. Just like you said at the top of the hour. Okay, last question is from Oscar Beltran. Hello, who can fill out a DBQ for mental health? Can a nurse practitioner, a psychologist, or counselor do it, or does it have to be a psychiatrist? Thanks for your help. Good question. Anyone can fill it out, but VA is going to look most favorably on the psychiatrist or psychologist, because those are the people who can do C&P exams for mental health. So VA is going to want those same criteria doing your DBQ. I have seen them filled out by nurse practitioners or mental health counselors, because sometimes veterans don't see a psychologist or psychiatrist, but they see another type of practitioner. If you see a psychologist or psychiatrist, that's who I would recommend to fill it out. Kind of go up the chain, so to speak. Allison?
I agree. If it's the initial and you're trying to get it service connected, it should be a psychologist or a psychiatrist. If it's increased rating, then maybe you can get some more leeway with like a nurse practitioner or a PA. I'm trying to think of the C&P exams I see for mental health. I don't think I see anything besides psychologists 95% of the time, and maybe psychiatrists like 5% of the time. I think that's an unwritten requirement that it needs to be one of those two. Now, for increased rating, like I said, you may have more leeway with it, but to be safe, if I can get a psychiatrist, I'm doing psychiatrist. If not, then I'm doing psychologist. If not, then I'm doing an ARNP or a PA. Then I'm doing the licensed mental health counselor.
All right. Well, those are all the time we have for questions today. Thank you so much for watching, and thank you for your questions. We actually really like doing this, believe it or not.
Yes. And whenever they ask us to come back, we'll be back. And if you have any topics you want us to do videos on, like I said, I'll already tell our video guy that we want to do one on hearing loss. Maybe I'll do it. Maybe Rachel will do it. We'll make Rachel do it. But I hope everyone has a great day. Thank you for your time. Make sure to like and subscribe, and we'll see you next week.